Okay, welcome everyone. Good morning, good afternoon, and good evening. Thank you very much for joining us for another Brain Health Unit Global Clinical Exchange Platform meeting. I'm delighted that today's meeting is being chaired by Professor Kameshwar Prasad from India, with a presentation from Professor Omar Siddiqi from the US. I'll hand over now to Professor Prasad as chair of this meeting. Thank you very much.
Good morning, good afternoon, good evening. I know people are from all over the world. I must tell you that I'm delighted to be able to present or to chair this session which Dr. Omar Siddiqi is going to present. I'm a professor of neurology. I worked for 40 years in All India Institute of Medical Sciences, New Delhi, and retired from there as Chairman of Neurology and Chief of Neurosciences Center, and then moved on to a relatively underdeveloped province of India called Jharkhand, and I am Chief Executive Officer of Rajendra Institute of Medical Sciences in Ranchi. So it's my great pleasure to welcome all of you, and I want to introduce Dr. Omar Siddiqi, who is going to make the presentation. But just a few remarks. This topic, coma, is really fascinating. And we have, I think, we as a student, all of us perhaps remember Plum and Posner's book of Diagnosis of Stupor and Coma was something which we read as Bible. And we should recognize that the first edition of that book came in 1966, and almost close to that book, Miller Fisher also wrote a book which was published in 1969. And from that time onwards, this book has undergone several editions, Plum and Posner's book, and it has become, I think, recognized all over the world as a classic text on diagnosis of stupor and coma. The most fascinating part of that book, which I remember as a student, was the progression of a patient with altered sensorium going into deep coma across various stages, which can be picked up by examining pupils, examining respiration, and such clinical signs which you can easily pick up, and yet you can predict what is the level at which this person is functioning. Is it diencephalic level? Is it midbrain level? Is it pontine level? Is it medullary level? And that was so fascinating that I hope students of today are also equally fascinated by reading the book with very clear diagrams. So that is one thing which I wanted to underline. The second thing was that in 1975, I think it was also a great advancement that Glasgow people in patients with head injury developed what they call Glasgow Coma Scale. I always say that it's not a coma scale, it's a consciousness scale, because the scale moves from 3 to 15, and as the score goes up, person becomes more conscious. So if you define scale by the way it progresses or how the scores differ across various levels of coma, it is a consciousness scale. I think that has been one of the greatest advance, though it was done with clinical sense, not much, statistical or quantitative assessment. And I have had the pleasure to do a systematic review of Glasgow Coma Scale, and I was so impressed that in spite of being clinicians, they did it so well, picked up the right science and right stages, which still helps people not only in head trauma, but perhaps all kinds of coma. So with this introduction, I think you certainly have great interest in listening to Dr. Omar Siddiqi. Omar Siddiqui is Assistant Professor of Neurology in Harvard Medical School, and he is also a visiting lecturer in University of Zambia School of Medicine. So I welcome Dr. Omar Siddiqi and look forward to your presentation.
Thank you, Dr. Prasad. I appreciate the opportunity to speak and welcome everyone for a very important topic that affects, obviously, patients all over the world. So Coma, approach encephalopathy, I have the benefit, as Dr. Prasad mentions, of working, I'm currently working in Boston, but I spent 11 years from 2010 to 2011 in Zambia, so quite a contrast. And so the approach to such patients is very different, a comatose patient. And so I will touch on that issue. And I know that some of our participants are from different settings with different resources. Sorry. So in overview of my talk, I'll talk about the definitions of coma encephalopathy, the neuroanatomy related to the presentation. I'll do a schematic of the approach and how to think about it in terms of diagnostic categories and generating a differential diagnosis, evaluation, and then I will end with a case, an actual case that I saw, and then there'll be another case after questions that we will use for discussion and a launching off point in the breakout rooms. So coma is actually a Latin form of the Greek word coma, which means deep sleep. And so the operational definition that one can use is a completely unaware patient who's unresponsive to external stimuli. So encephalopathy is actually is not the same thing. Encephalopathy is an alteration of mental status affecting cognition and level of arousal. Someone can be responsive to external stimuli from an encephalopathy. Coma represents the extreme spectrum of severe encephalopathy. And so this isn't, I think for the purposes of this talk, we'll be talking about the most severe form of encephalopathy, which is coma. So just the anatomy, I think the important things to remember for simplicity is the reticular activating system in the dorsal pons in the midbrain, outlined by the dots here in the center of the diagram. And then it's projections. So, these are very, very complex projections, but for the purposes of what you need to know towards a clinical approach, there are projections to the thalamus, but to the cortex. Think about the reticular activating system, the arousal system, and its projections to the cortex. So why are these things important? So, because the cortex and the reticular activating system help maintain consciousness, one of my mentors from medical school, and this is a very simplistic, but it still works. So, 20 years of practicing neurology, it still works really well, which is what you need to maintain consciousness is the brainstem and one cerebral hemisphere. And if you don't have that, then you will not have a conscious patient. So on the right is a demonstration of the various herniation syndromes. So just talking about how someone can become comatose using the brainstem and one hemisphere model. Well, let's just say this, the epidural hematoma that's here, that is compressing on the brainstem, and then that might cause the temporal lobe to push against the brainstem, causing the reticular activating system to be compromised, and that would cause a comatose patient. At the same time, if you just impinge upon the brainstem, that could be upward cerebellar transtentorial herniation from a stroke. It could be from a bleed that then impinges upon the brainstem. That would cause a coma. You could have a trauma or brain edema that affects both cerebral hemispheres with the brainstem being intact, and that would also result in coma. So this idea of the brainstem and one cerebral hemisphere has worked well for me in terms of what was causing coma. So for a differential diagnosis, I would say there are 4 buckets to think about. One is the neurological category bucket, metabolic causes, more diffuse causes, and then psychiatric, and I'll go into each of these in detail. So for neurologic causes, certainly an ischemic stroke based on its location, not all ischemic strokes, but certain ischemic strokes, particularly brainstem strokes or really, really large infarcts with swelling, can cause a coma. Hemorrhagic stroke, a large hemorrhagic stroke, or if it bleeds into the ventricular system, which then causes, a brainstem dysfunction or compromised cerebral hemispheres. Subarachnoid hemorrhage, a subdural hematoma or an epidural hematoma, like I pointed out in the previous slide. And then seizures, in particular, non-convulsive status epilepticus. So, not all seizures are convulsive. So you can have a patient that is comatose, they're not convulsing, but their brain is in status epilepticus based electrographically, based if you hooked up an EEG to them. And I think that's probably an underdiagnosed cause of coma worldwide. And we've actually done some research on this in Zambia. CNS infections, meningitis, encephalitis, brain tumors or metastases, hydrocephalus, and some of these all don't happen in isolation. So certainly you could have a hemorrhagic stroke that causes hydrocephalus that then causes coma. You could have encephalitis causing non-convulsive status epilepticus, etc. Metabolic causes, so disorders of serum sugar, so hypo and hyperglycemia, severe hyponatremia, hypercalcemia. These tend to be extremes to get to the point of coma. Hypothyroidism, liver dysfunction resulting in hyperammonemia, also severe renal dysfunction resulting in uremia. So those should, in terms of metabolic differential, you should be testing for all of these things in a comatose patient if you're unclear on the diagnosis. And then diffuse causes. So this tends to be toxicity and drugs. So alcohol toxicity, opioid toxicity, so going along with the huge opioid epidemic that's particularly going on in North America and other places, drug overdoses, poisoning, and hypothermia. And then psychiatric causes, not common, but particularly in someone who's got a history of psychiatric disease, depression, severe depressive catatonia, the patient can look comatose. So the evaluation, history and examination and investigations, but it's different, right? Because the history is not coming from the patient and the examination is limited. So I'll get into this and what you should be looking for and the approach you should take. So in terms of history, you are not going to be talking to the patient unless it's someone who's been hospitalized for a prolonged period of time, but most of the time it's going to be collateral history. And that will be from their relative, that will be from hospital records, that will be from their medications or from pharmacies, et cetera. So you often have to be in information gathering mode, particularly if the patient is alone. Timing. So the timing is very, very important. If acute causes, meaning hours or over the course of a day, subacute, days to a week, chronic, weeks to months, someone who's slowly progressing and enters into a coma over a long period. And then drug history, particularly related to overdoses. So examination, I think the first thing is the ABCs. You want to make sure airway, breathing, and circulation, particularly comatose patients that are not protecting their airway. That is crucial as an immediate step. Professor Prasad mentioned the Glasgow Coma Scale, which is really a Glasgow, consciousness scale, but it's a measure out of 15 of spontaneous eye opening, verbal output, and motor, response to pain or spontaneous movements, 15 being fully conscious. And the lower you go, the worse it is, 3 being the lowest score. So coma is defined by the GCS, the abbreviation, less than 8. So GCS is very, very important to actually just assess if someone is in fact in coma. Then motor responses, if they are in a coma, you want to see if they have any movements at all. Are these reflexive movements? Are they purposeful movements, which would indicate maybe they're more on the moderate encephalopathy scale rather than coma? Is there any asymmetry, which would indicate whether they have a structural lesion? Are they paralyzed on one side? Are they withdrawing to pain, but completely flaccid on one side of their body. And then the eye exam. The eye exam, and I'll get into this more details, incredibly, incredibly important, particularly related to the pupil size and the fundoscopic exam. There is a whole literature about this, and particularly stupor and coma in terms of the respiration patterns. Kussmaul, respirations, Cheyne-Stokes. I didn't get into this because in 15 minutes, you had to sort of cut some stuff out, but that is within the stupor and coma literature and other literature can actually indicate where the level of the lesion is if someone is comatose based on their breathing pattern, but I do not get into it here as a disclosure. So pupils, incredibly important. So here is pinpoint pupils. So opioids, pontine lesions, particularly we often think about a pontine hemorrhage. If someone is unresponsive to light and has moderately dilated pupils, you think about a midbrain lesion compressing the oculomotor nerve. If you are maximally dilated, 8 millimeters or greater, you think about drug toxicities. And then if it's asymmetric, so as pictured above, you see the left eye is dilated. And so you would think about a third nerve compromise, something like an uncal herniation, the temporal lobe impinging upon the midbrain, causing a pupillary defect. And the fundoscopic exam, incredibly important. So on the left is a picture of papilledema. You can see that you've lost the optic disc margins, and it's very, very blurry. So that can be an indication of ICP, elevation, someone who's got, really, really bad hydrocephalus related to a brain bleed, cerebral edema, et cetera. On the right, again, there's papilledema, but also there's retinal hemorrhage. So the case on the right is subarachnoid hemorrhage. So these are things that in a non-responsive patient you can look at that can give you a clue about the cause of coma. So in terms of investigations, the immediately right in front of your eyes, I think, most settings have glucometers. So you can check for hypoglycemia or hyperglycemia and treat that with IV glucose or insulin. Suspected opioid toxicity, not in every setting, obviously, but we do have reversal agents, naloxone for someone with opioid toxicity. That can be an immediate way to wake someone up. And then in terms of blood, you'd want to get sort of during, within the hours of their hospitalization, a full blood count to test for infection, clotting disorders, chemistries for the metabolic disorders I outlined, liver function tests, and a toxicology screen for overdose. Chest X-ray is valuable. Signs for something like tuberculosis or pneumonia that could be causing sepsis, infections, and infections. Particularly in Zambia, we often saw, I would say the large majority of our comatose patients were from infectious causes. So things like a urinalysis, blood culture, along with the baseline laboratories you get, and then imaging. So this is resource limited based on where you are. I think all comatose patients where they have access to imaging will get at least a non-contrast CT scan, potentially an MRI scan, because for things like ischemic strokes, can be missed acutely on CT scan. But I acknowledge that all places do not have this in the settings of some of the people on this call, and that's something that's worthy of discussion. A lumbar puncture, particularly in places where you have a high level of meningitis, encephalitis, or someone comes in febrile. But there's another issue. If you don't have imaging, when is it safe to do a lumbar puncture? And that's not an easy question to answer, and different people have different risk tolerance for doing it. And then EEG, also another resource. Actually, I would argue getting easier to implement in more less resource settings, but that for non-convulsive status epilepticus. So I will end with a case that I saw to just highlight some of the things I've talked about. So this is a case that I saw in my first few years in Zambia. It's a 35-year-old Zambian male with HIV and presented with confusion over a period of 24 hours, brought in by the family, who relayed, the patient could not relay the history, and it was not comatose immediately. He had been compliant with his HIV medications over the last year and had reconstituted his immune system with a CD4 count of 550 cells per microliter. And initially, when he had presented, he had cognitive impairment and a presentation consistent with HIV neurocognitive disorder, or HAND. And he was admitted because of the confusion, and over 12 hours became unresponsive and comatose. So was afebrile. The blood pressure was normal. The heart rate was slightly tachycardic. The respiratory rate was 14 and was normal oxygen saturation. Did not need to be intubated at that time when they were admitted. The Glasgow Coma scale was 7. Interestingly, the eyes were spontaneously open, but no verbal output and minimal motor response. The pupils were equal round reactive to light. There was no signs of elevated ICP or problems with the retina, sharp optic disc margins, normal tone, and normal reflexes. So not a lot of revealing information based on that exam. We had gotten the recommended baseline screening laboratories, normal sugar, normal UA, blood, chest X-ray. So a bit perplexing. We were in a setting where we could get, this is not his imaging per se, but very related, which showed cerebral atrophy. And so there's this subcortical white matter disease, which could be signs of other infection, but in saying other things in the normal immune system, this was actually consistent with prior imaging the patient had had. I acknowledge that not all patients could get imaging. So it was still a clinical conundrum, but based on this, we felt like we could do a lumbar puncture safely. And the lumbar puncture was acellular, 0 whites, 0 red blood cells, and normal chemistry. So again, unrevealing. What do you do in this case? Well, we didn't have a great answer for why this patient was comatose. We did have access to EEG, which showed generalized discharges consistent with non-convulsive status epilepticus. We gave this patient Ativan and phenobarbital, and they woke up. So, this is in Zambia in the most well-resourced hospital. But this patient without the benefit of EEG, when you're faced with this, one thing you could do is just give Ativan to see if they wake up, or empirically treat for seizures. But this was a challenging case and just shows you the heterogeneity of the presentation. I will stop there. It's my team in Zambia, and I will take questions.
I wondered if I could ask a question, Dr. Siddiqi, before we go to the breakout to get things going.
Sure.
What's, in those settings where EEG may be available, but it's limited and you have to think about cost and service utilization and things, what have you found useful as the clinical clues to the fact the patient may be in subtle motor or non-convulsive status in terms of etiology and clinical features and demographics and that sort of thing? Thank you.
Yeah, it's not an easy question, but a very important one. So what are the clues that you can have if you don't have the benefit of EEG in determining someone's a non-convulsive? So there is this phenomenon called hippus, which is, this pulsation of the pupils, which has been described in non-convulsive status epilepticus. Certainly if they have a prior history of epilepsy, that could be a clue. If they have other metabolic disorders like hyponatremia, which would predispose them. But, it's non-convulsive, right? So if you're in a comatose patient, it's very, very subtle. I have a love-hate relationship with EEG because, you could say, you could just get an EEG. EEG requires a lot more than just the machine. I think that's just 10% of it. Even you need someone to read it and be able to read it properly. And, this idea of remote reading, but, someone who's in non-convulsive in front of you, waiting for them, sending it somewhere for reading anyway. I have a lot of excitement for cell phones. I think cell phones has broad coverage in a lot of regions and can help in some way, shape, or form. But it's challenging, and I think we miss it. And Ben, full disclosure, Ben and I worked together, and we did a study in patients with altered GCS in Zambia, and I think we found like 17% of the patients within the just normal hospital wards, impaired consciousness, had signs of non-convulsive status epilepticus or suggestive of EEG proven.
Yeah, and maybe if I may add, one has to be very, very careful in examining also. Sometimes, even though non-convulsive, flicker of movements, which may be repetitive, may be missed unless one is careful. And that kind of involuntary flickers which repeat, maybe it's eyelids, maybe just corner of the angle of the mouth, maybe slight clue that the person may be having actually you can't call it non-convulsive very strictly, but maybe patient is in status. So sometimes not a full-blown convulsive status, but somewhere between non-convulsive and convulsive status. So one has to have high index of suspicion, I think, in situation you described, Omar, where everything is actually negative. One has to think about this possibility.
Yeah. So there's a question, are there any other features on EEG that could help get to the bottom of diagnosis? My experience is that beyond status, EEG is often non-specific and not helpful. That's a great question. So I would say surprisingly two things. So EEG, certainly its best role is to see if there are discharges that would suggest there's a predisposition for seizures or if a patient's actively seizing. I will say that it can be a very poor surrogate for imaging in that you can see if there's hemispheric dysfunction. One side is slower than the other. It doesn't point you to an etiology, but it would say that there's a structural problem on one side of the brain over the other. The other is cardiac. So certainly if someone is, severely bradycardic, having long pauses, there have been times where it's not the EEG, it's actually a heart issue, and then that can help. But those are the two. But yeah, it's not super specific etiology, but it can tell you about structural lesions if you don't have imaging.
Omar, thank you very much for the talk. Just a question for myself, if that's okay. So once you get to that point where, everything's coming back normal, the imaging is fairly unremarkable, the LP is unremarkable, and you get to this kind of point of diagnosis of exclusion, you quite rightly said you're left with non-convulsive status. And to my mind, the kind of psychiatric causes that you'd mentioned are also still in the differential at that point. You'd mentioned that giving Ativan or some sort of benzodiazepine to see a response is reasonable, and you can do that empirically. But maybe I'd be a little bit nervous if my other differential is depression or catatonia, and I'm going to drop the respiratory rate and put them into respiratory arrest. Any pointers? So let's say truly, clinically, you couldn't find any markers of non-convulsive status at all. No flickering of the corner of the mouth or the eye or anything. Is there any particular things that point you towards catatonia that would be, or depression that would be useful to kind of rule that out at least?
Yeah, great question. And so are there clues that would lead you towards a psychiatric cause of the coma rather than neurologic cause or some other? Obviously the prior history, I think, would be the most thing, particularly psychiatric, right? Psychiatric, someone's not going to go into depressive catatonia out of nowhere, relative to seizure. So that's helpful. What's interesting is that I believe this, I'm not a psychiatrist, but I believe the treatment for catatonia is benzodiazepines, which is an interesting thing, but I would think it would be history. I thought it's diazepam. I could be wrong about that. But yeah, beyond history, I don't know for both of them. History of epilepsy, history of depression. Often epilepsy patients have the history of depression as well. So that can, you can conflate those two things.
Sure. Tricky. Thank you.
One question on the chat box, Omar, a quick question, I think. GCS is not reflecting brainstem function. Do you have any other scales that reflect brainstem reflexes and functions?
I mean, obviously, the best thing we have is our neurological exam, right? The cranial nerve exam is a surrogate for brainstem function. So that is when you're checking for eye movements, you're checking for vestibulo-ocular reflex, the doll's eye reflex. You can do things like cold caloric testing, though full disclosure, I've never seen cold calorics work, though we use it. And I'm almost ashamed to say it, but I haven't. But it's used as a, it's even in the stupor and coma book, to see if they're brainstem. So the cranial nerve exam is the best thing we have, gag reflex, initiating spontaneous respirations, et cetera, for brainstem function.
Right. So maybe we should break out now. Maybe Greta, can you help us to?
Oh, let me give the case. Actually, sorry for discussion.
Yeah. Right. Sorry.
Apologies. So this is just a case to facilitate discussion in the breakout rooms. So this is a very general case that would apply to all settings. A 45-year-old female with a past medical history significant for hypertension collapses in a bar. Per the friend who was with the patient, she had been complaining about a headache and blurry vision in the hour prior to the collapse. She's on a beta blocker for her hypertension, and she is a smoker. When she's brought in, she's afebrile, is hypertensive to 150/100 with a heart rate of 110, slightly tachypnic, 22, satting 98% on room air. Her GCS is 5, so really comatose and eyes closed spontaneously. There's pupil asymmetry. So the left side is reactive, the right is unreactive. The optic disc margins are sharp, so nothing on fundoscopy. Normal tone, no movement at all to noxious stimuli. And this is her eyes. This is not a patient. This is just an image, but just deviation to the right. You may not see it, but dilation of the right pupil relative to the left, which may help with localization. So just some questions for discussion in the breakout rooms. What's the differential diagnosis in such a patient with an acute presentation? What investigations are of interest? How does a diagnostic and treatment approach change if this patient presented a well-resourced setting versus a rural hospital in a low-income country? And then lastly, what are the research and service optimization priorities for coma patients globally that we can think about?